Hi everyone, thanks for coming back. Today we are looking at legal policy issues affecting the U.S. healthcare system, and we put these in our forest and tree metaphor as one of the clouds that creates issues and needs and problems in the healthcare system. So joining us today we have Professor Mello, who is a professor of law and public health here at the Harvard School of Public Health and one of the nation's leading experts on medical liability reform. So we hope you enjoy it.
Medical malpractice is a niche area of law, so why is it included in a course on U.S. health policy? There are a few reasons why this area has become a really important health policy issue, something that we think affects healthcare delivery and the cost and quality of healthcare, as well as people's ability to access it. Let's talk about a few of those reasons now. One reason is the cost associated with so-called defensive medicine. It's widely believed that when physicians think they're under pressure of being sued, they're much more likely to order extra tests and referrals and other services, primarily out of a fear that they may be sued, and that ordering those extra things might protect them in the event of a lawsuit or dissuade a patient from bringing a lawsuit. These so-called assurance behaviors are highly prevalent. Almost all physicians say they engage in them sometimes or often. That's even in areas that in objective terms have relatively low liability risk. What's less clear is exactly how much they cost us, but there's wide agreement that the number is a big one. In a study that my colleagues here at the Harvard School of Public Health and I did a couple of years ago, we estimated that at a national level, defensive medicine costs range for about $45.6 billion annually. Now that's a lot in absolute terms, a relatively small share of overall health spending, about 2%. But in an era where we're looking for low-hanging fruit, areas of waste in the healthcare system to try to trim and bend our healthcare cost curve down, defensive medicine is an obvious target and probably the main reason why health policymakers at the state and federal levels are interested in trying to address the problem of medical liability. A second reason why this is an important policy problem is the possibility that the pressure that physicians feel themselves to be under may be affecting the supply of healthcare services in the U.S. This is a heavily contested claim. Lots of physicians and hospitals have lobbied hard for malpractice reforms with the argument that they're going to be forced to shutter their doors, stop serving high-risk patients or doing high-risk procedures, or in other ways curtailing the supply of services if they don't get some relief from high insurance costs and the uncertainty and potential catastrophe of a lawsuit. How true are these claims? Well, when you look at studies of physician supply across the states, it's actually quite hard to detect an effect of medical liability on our nation's population of physicians. But states that have strong tort reforms in place do see modestly higher levels of physician supply. What about when you ask physicians about their intentions? Well, here you get a little bit of a mixed message. When we surveyed high-risk specialists in Pennsylvania at the Harvard School of Public Health several years ago, we found that really high proportions, up to about a third to a half of high-risk specialists, said that they definitely or would likely do things like leave the state and find a lower-risk state to practice in, stop accepting high-risk patients like obese people or lawyers, or stop offering high-risk services like deliveries for high-risk pregnant mothers. But when we looked at what actually happened, we saw lots of them doing that, but actually that happens a lot, even before a period in which malpractice costs intensify. So the bottom line, this probably goes on modestly. It creates a lot of stir, particularly at the national level in policy debates, about the possibility that it may be going on more. And a lot of that policy concern is driven by highly compelling anecdotes. The hospital in inner city New York City that has to stop offering obstetric services, for example, or the town in Idaho that loses its last remaining obstetrician. And these anecdotes have had a powerful impact on the policy frame around this issue, converting it from essentially a dispute between the insurance industry and doctors to a public health issue involving access to care. A third reason why we might think about medical liability as a health policy issue is the potential power of our medical liability system to further an important health policy goal, which is to better understand medical injuries. Medical injuries are a leading cause of death in the United States. The Institute of Medicine reports they may be responsible for as many as 98,000 deaths in American hospitals every year. So it's a significant public health problem. And we've only recently come to recognize that malpractice claims themselves are a kind kind of detection system or surveillance system, just like we use in other areas of public health, to try to understand a major area where we should be focusing our attention. So by looking at the most severe claims and at patterns of claims that we see representing in this system, we have an opportunity to learn about opportunities for improvement. And one of the big challenges in health policy right now is that although scientists recognize the value of these claims, many hospitals and especially physicians don't take malpractice claims seriously as a quality signal. And that's because of the well-known fact that lots of claims don't actually involve negligence or even a cognizable medical injury. They're so-called frivolous claims or otherwise non-meritorious. So there's a high noise to signal ratio here in this system. And so the challenge for scientists in this area is to try to extract the useful information from a surveillance system that's filled with a lot of noise. But there is a lot of useful information that we can use to improve patient safety there. The last reason why this is an important health policy issue is that the system that we have designed to take care of disputes about medical injuries can itself have perverse effects on the very problem it's trying to solve, which is patient safety. What we hope is that the signals that the tort liability system sends to doctors encourages them to make safer and more socially optimal decisions about care. In fact, that doesn't seem to happen very much, as I'll talk about more later in this lecture. What we do see happening quite a bit are more perverse effects, where instead of more learning and adjustment of practice patterns to foster safer care, we have a tendency to drive information about errors underground because of the highly punitive, adversarial, and just plain awful system that we have for resolving disputes about medical injuries. To avoid lawsuits, doctors will do just about anything, and that has really chilled discussion and learning about the very problem that malpractice suits target. So for all these reasons, malpractice has risen from something that lawyers and doctors think a lot about to something that U.S. health policymakers have been thinking a lot about. That attention has focused in the last several years also in the academy on understanding how well our current system works for addressing the problems it attempts to solve. And we'll talk about that topic next.